Friends, for the next talk, we are having an interesting topic. And till now, we were using HbA1c as gold standard for monitoring the diabetic control. And now we will be having a talk and in which we will discuss the new concept of time in range that will, I think, overcome HbA1c as a tool to follow the progress of diabetic control. And Dr. Sudhir Tripathi and is there with us, and he will talk about time in range and the role of second generation basal insulin in managing time in range concept. Dr. Tripathi, please.
Thank you, Mr. Chairpersons, friends and colleagues. It's a great pleasure to be here this morning, and I would like to thank the organizers for a wonderful organization of the SPEEDCON. So it's turning out to be a very good professional event for the calendar year. Secondly, I'd also like to pay tribute to Dr. Sujit Jha, who passed away a couple of months back or weeks back. And he was an endocrinologist, worked with the Max Hospital Group. And I had the opportunity of chairing a session on time in range workshop 2 years ago, where Dr. Sujit Jha gave a wonderful talk on time in range. So I think we must pay tribute to Dr. Sujit Jha, who passed away a couple of weeks back, I guess. The next thing I would like to say is that when we talk about time in range, we know that the therapeutic armamentarium for type 2 diabetes has evolved over the last couple of years. We have a plethora of oral drugs and lots of new insulins. The second generation basal insulins are here, and we still have shortcomings. We still have hyperglycemia, we still have hypoglycemia, we have complications of diabetes, so nothing much has changed, despite all the advances that have taken place. Only thing, we have more choices, and therefore, the role of HbA1c has also been called to question. We know in the 1980s, self-monitoring of glucose was used. The DCCT trial was published in 1991, and in 1992, when we started our DM program in AIMS, we felt that 7 times blood sugar monitoring was a great thing. So that was self-monitoring of blood glucose. Then came along the HbA1c, and that was considered the gold standard of treatment for monitoring for type 2 diabetes. However, even that has changed, and now we know the shortcomings of the HbA1c, and that has led to the evolution of the continuous glucose monitoring and time in range. So that's the new concept, but I'm sure that's not the end of the story. Because even that a couple of years later will fail and something else will come. But what I'm surprised about is the fact that despite hundreds of years of diabetes, we still are struggling to find a measure to just monitor the sugars. That's surprising that you have self-monitoring blood glucose or HbA1c or time in range. So we still haven't formulated a strategy as to how we should go ahead with the patient's management despite these shortcomings. Thanks. So now we come to the first part of this talk, which is the concept of time in range and clinical implications of the time in range. And this is the concept of time in range, which we shall discuss at length, and also subsequently the generation 2 basal insulins. And these are metrics of monitoring of diabetes which were used in the past. We spoke about the self-monitoring blood glucose as well as the HbA1c. You know, the HbA1c has a lot of drawbacks. I'll not go into them. Suffice it to say that HbA1c is not adequate for the monitoring or the treatment of type 2 diabetes, and therefore the new concepts of time in range. And that brought us to the beginning of the continuous glucose monitoring, which came in about a decade or so ago, 2001 I think it came. And this CGM, or continuous glucose monitoring, is a device that provides 24-hour real-time glucose levels, and also provides the rate of change of blood sugar, and also gives you an alert about hypoglycemia, hyperglycemia. So that's a big advantage of the time in range or the glucose monitoring, which is not there with the HbA1c molecule monitoring device. So this is just a brief overview of the continuous glucose monitoring system. You have a sensor which you place in the body that picks up the glucose from the tissue and transmits into the form of an electrical signal which goes to the receiver, and therefore the signals are transmitted, and you can get a 24-hour real-time level of the blood sugar levels. And also it gives you an alarm whether the blood sugars are going down or the blood sugars are going up, so that's a big advantage. But what the problem with the CGM was that a lot of CGM companies were there and a lot of CGM data was available, but no one knew how to interpret the data. You had pages and pages of, the patient would get a 7-page report with all the lines and multiple colors drawn across it, but no one knew what to do about it. So that brought us to the question, how do you standardize the report of a CGM? And that has brought us to the question of the ambulatory blood glucose profile. It's called the AGP, ambulatory glucose profile. This is a single-page summary of the blood glucose data which is generated by the CGM. This is very important because it gives a brief summary and exactly what the CGM has brought into focus. So after doing 14 days of monitoring, you get the AGP, which will tell you how you should go about your patient. So this is what the AGP is about, ambulatory glucose profile. It has 3 parts to it. This is a freestyle Libre report, which you see on top is the glucose statistics and targets. That just tells you what the average glucose is, what the glucose variability is, what the glucose management indicator is. That's a new concept. And also the date which it was done, the number of days it was done, the number of times the patient wore the device, and also the other thing like percentage of time that the CGM was used to collect data. So that's the first part which is important, the statistical part. The next part which we often remember is this graph, which you must have seen umpteen number of times. This is the visual display of the CGM data. And this shows 3 or 4 things. One is the dark blue line, which is the median curve, which shows the degree of glucose stability. You see the dark blue line in between. And then you have the blue shaded area in dark, which is the interquartile range, which is about the 25th to 75th percentile. And then you have the outliers, which is the values less than 10%, and that is either hypo or hyper, and these are shown in the light blue color. So this is a graph that you typically get. And then you know much about glycemic variability, so we shall not discuss glycemic variability. Suffice it to say that glycemic variability refers to the fluctuation in blood sugar, which is also picked up by the CGMS, which is not picked up by the HbA1c. And this fluctuation of peaks and troughs is very important because they are responsible for the complications. So if you want to prevent complications, you must make sure that your peaks and troughs are taken care of. And this shows within day, intraday and day-to-day, inter-day variations are important. That's called glycemic variability. That leads to high oxidative stress, and of course we know the severe complications of type 2 diabetes or even type 1 diabetes. So that brought us to this question of time and range. And this time and range is a very interesting concept, and this evolved over the years. It has been evolving since 2000 odd, once the CGM came in place. And I remember time and range was first sort of brought into focus by Dr. Robert, I think his name was Robert Maze, from the International Diabetes Center in Minneapolis, and he has done a lot of work on this. And if you see, in 2012, the Helmsley Charitable Trust, it says here, provided the first expert panel on target time and range, and then over the years it has evolved until it was 2019. I think you must remember 2019 as the inflection point in time and range, when the ATTD suggested, they had an international consensus conference, and they gave out the guidelines on what time and range should be and how it should be interpreted in clinical terms. Not just do the CGMA, but you must interpret it adequately so that the patient benefits. So 2019, hardly 2 years back. And in the last 2 to 3 years, it's a short time for the thing to have evolved very greatly, but I'm sure the next decade or so we'll see a lot of the time and range. And in 2019 this evolved. In 2020 the ACE, ADA and other organizations have brought into focus, saying that it's very important to do this time and range. And this is something about what the time and range looks like. You see the various parts of this. This is the green bar is very important. That's the time and range, that you want to keep the blood sugar between 70 to 180 milligram per deciliter in most patients, and this should be about 70% of the time. So in a 24-hour period, 70% of the time your sugar should be in this range, which amounts to about 16 hours and 48 minutes. And this is the time and range. We also know that sugars often remain very high, and that's the thing on top in the yellow bar, which shows if you have a blood sugar more than 180 milligram per deciliter, it should be less than 25% or less than 6 hours in a day, the blood sugar should go up. And right on top is 250 and above blood sugar, which we call severe hyperglycemia. It should be less than 5% of the time in a day, that is roughly less than 1 hour and 12 minutes. So that's the intricate distribution of the time in range as well as the time above range. So this is the time above range, this is the time in range, and of course what is most important is the red, which is the time below range, and that is hypoglycemia. That leads to increased cardiovascular mortality, and a lot of drugs cause that, like sulfonylureas, insulin, and any drug which causes hypoglycemia. So you should avoid hypoglycemia. So less than 70 milligrams is hypoglycemia. It should be less than 4%, which is less than 1 hour. And less than 54 milligram per DL is really terrible, and that should be less than 1%, that is less than 15 minutes. So less than 15 minutes of the day, you should have, it's not that you should have, you could have HbA1c less than, time below range of less than 54, but the idea is to avoid that altogether. If you have 100% time in range, that would be what the optimum target would be. So this is a very important bar to remember, and of course there are variations of this bar. You have old persons who have a different level of HbA1c time in range, as well as the patients with gestational diabetes who have a different level for time in range. Gestational diabetes, you know, the lowest blood sugar can be up to 63 to 140. That's the time in range for gestational diabetes or pregnancy diabetes. So this also just exemplifies the importance of time in range, and what's above and what's below from in range. People with diabetes, as I said, should spend 17 hours a day in approximately 70% of the time. That's the time in range. Blood sugar should be in this range, and we have already spoken about very high, very low, etc. So this is called level 2 hyperglycemia, level 1 hyperglycemia, similarly level 1 hypo and level 2 hypo. So that's the distinction between these various sub-entities. So now we know that time in range has come to stay, but we still don't know whether it is responsible for the complications. There's very little evidence to that effect, and this has come only, as I said, in 2019 time in range was brought into focus, and this shows that time in range has been studied where it is deranged by about 10%, leads to retinopathy risk increased by about 64%, nephropathy risk increased by 40%, and neuropathy risk increased by about 25%. So there's data to suggest, but this is small data, early data, and this suggests that it's possible that time in range may be correlated with the development of microvascular angiopathy. Similarly, there's some data, initial observation and evidence that shows that increase in the surrogate markers of macrovascular complications such as carotid intima media thickness may also be happening because of deranged time in range. And this is recently published in 2019, 2020. This is all recent data. And we come to another study, this is a study which was published in 2021, in Diabetes Research in Care 2022, this year. Time in range as measured by continuous glucose monitoring as a predictor of microvascular complications in type 2 diabetes. A systematic review, most of them are Indians, that's very interesting, and they said that study affirms a significant association between CGM-derived time in range and microvascular complications of nephropathy, retinopathy, and polyneuropathy. So there is definite evidence which is evolving that time in range is important for the development of microvascular complications and possibly even macrovascular complications. So obviously we are moving away from HbA1c, but I must say that HbA1c is not over and out. This is just a complementary tool. If you have HbA1c, self-monitoring blood glucose data as well as time in range, then that sort of puts everything together. You can't say that we won't do HbA1c, just do time in range. That's not possible. It's an expensive test, the CGM, no one does it, not very many people do it in India, and still no data on how much it should be done. You should do it 14 days in 3 months or 1 day every day. Type 2 diabetes, what should they do? Type 1 diabetes, what should they do? Are they on insulin? What should they do? So this is still evolving field, and let's see what interesting evidence we can get out of this talk. So this is just some of the world organizations which have focused on this. This is the ATTD, which is Advancing Technology and Treatments for Diabetes. This is an organization which I said convened the 2019 meeting which brought into focus this concept. And I said here it's pregnancy, which we have not discussed, which shows that the target sugar level is 63 to 140. So the time in range is different here. It's different in a type 1, type 2 diabetic. It's different in older high-risk populations where you don't want the sugars to be too low or too high. So similarly, the time in range varies from pregnancy and old age people. Then this also has been taken over, this concept has been taken over by the ADA in 2019, 20 and 21. The highlight is on time in range. So everyone is jumping on the bandwagon. The time in range is very important, and this makes sense. And time in range, as you've seen, is associated with microvascular complications, can be used for assessment of glycemic control, and additionally, time below and above range are also important. So this very small print here shows that in the ACE guidelines says lifestyle therapy and ongoing glucose monitoring, CGM is preferred. So it is coming about, and hopefully in the next couple of years we should have more and more of CGM. Now we come to the last part of the talk, which is in fact the most important part, I think, because we're focusing on the generation 2 insulins, the long-acting basal insulins. And we know that there are 2 long-acting basal insulins which are called the Gen 2 insulins, which is one is degludec and the second is glargine 300. The first generation, of course, we know are glargine 100 and the previous what is called Lantus. Lantus, in fact, has been the torchbearer of the generation 1 insulins ever since it was introduced in, I think, 2000. For 20 years, it has stood the test of time and is still going strong today. So this shows that there's a suboptimal clinical utilization of time in range is important yet seldom measured. So that's the problem with time in range. And if it's seldom measured, what do you do? So whether the treatment solutions can take care of time in range even though it is not continuously monitored. And can basal insulin address these issues of glycemic variability and time in range? So yes, they can, and we know that basal insulin affect the glycemic variability. Peaks and troughs are monitored and taken care of. The troughs cause hypoglycemia, and the hypoglycemic excursions are caused by the fasting sugars, and basal insulin glargine effectively controls both PPG by hitting at the base, as well as it offers flexibility of using PPG targeting OADs and lesser risk of with glargine versus NPH of hypoglycemia, and we all know this because this is what we've been using for the last couple of years. Now we come to the CGM evidence for generation 2 basal insulins. We all have heard about the BRIGHT study and the CONCLUDE study, which was touted as the main head-to-head study between glargine 300 and degludec. Those studies, however, based on they were based on HbA1c and finger stick self-monitoring blood glucose. They are not based on the CGM. So we're not talking about the BRIGHT study and the CONCLUDE study. The BRIGHT study showed a bright future for the glargine, and the CONCLUDE study was inconclusive. But we come now to the studies which have assessed the CGM evidence for generation 2 basal insulins. And this is the degludec versus glargine 100, which we shall not discuss. This was the Switch Pro study. And glargine U 300 versus 100, we should also not discuss. What we are discussing today is degludec versus glargine U 300. That is important. These are the two generation 2 next insulins. So what I'm going to do is the type 1 diabetes Clam study. This is a study that I will focus on. This was published in 2018. Subsequently, another study published in 2020. Type 2 diabetes. These are the two important studies, both from Japan and both published recently in 2019 by Kawaguchi and Yamabe. One care study, which is a real world study in 2020. Basal Plus versus IDEC as an in-range study, which is yet to be published in type 1 diabetic patients. So these are the various studies that we shall try and cover. This is the first study. This is the type 1 diabetes Clam study. Glargine 300 has lower within-day variability versus IDEG 100. So that's the sum and substance of this, that it has lower within-day variability. As you can see from the graph, the blue line shows degludec, the green line is glargine, which shows that there is a subtle difference in the glycemic variability within day between these two molecules. So it favors glargine 300 in this study, and it shows 20% lesser within-day variability with glargine 300 compared to degludec. This further study is again in type 1 diabetic patients. This is a smaller study. They have just about 22 patients of type 1 diabetes, and it shows on the right and the left 22% greater peak effect with degludec compared to glargine 300, and on the right hand side is shown 23% lesser variability with glargine 300 compared to degludec. So the first two studies, that is the previous study and this study, both in type 1 diabetics, you see about 22 type 1 diabetic subjects, both show that the within day variability with glargine 300 is lesser than that compared with degludec. However, there is also data, not to say that there is no data for degludec. Degludec data is also there, which suggests that degludec has a lower within day variability compared to glargine. But that's a study which was published by Heath et al., and that is a Clam study, and there are several studies in that regard that show that degludec has lesser variability compared to degludec, compared to glargine 300. But the two studies cannot be compared because they are different studies, different populations, done at different times, so they are not comparable. But both show that the within the variability of these two molecules is almost similar, but there is a subtle difference between the two. The next study is this type 2 diabetes study, CGM study again, time in range of glargine 300 versus IDEG. Most of the studies were degludec and glargine 300, and I shall just come to the conclusion. So this studies the efficacy and safety of insulin glargine versus degludec, and time below range was markedly lower for glargine versus IDEG. So that's the second point. The glargine 300 had lower within day variability, and glargine 300 has also lower time below range or lesser degree of hypoglycemia compared to degludec. And this is particularly happening in the nights, and that is nocturnal hypoglycemia is less. Another thing which the BRIGHT study showed, I shall just refer to that during the titration phase of the glargine 300, the incidence of hypoglycemia is much less compared to degludec. And during the titration phase, if you have low hypoglycemia, then the chances that the patient would continue on the insulin is very strong, because they would not be fearful of hypoglycemia and would like to continue their insulin. If they have hypoglycemia, they just don't want to take the insulin. So percentage of time within the target range, there is no difference, but the hypoglycemia risk is. And if you focus here in the blue chart, anytime hypoglycemia, glargine 300 1.3, IDEG is 5.5, nocturnal hypoglycemia is less, and severe hypoglycemia is also less, glargine versus IDEG. And this is another study which shows the same data, which shows that there is significantly lower nocturnal hypoglycemia with glargine 300 compared to degludec. This is a real world study which also shows that there is better time and range profile with glargine 300 versus degludec during the night time. So nocturnal hypoglycemia is much lower. And finally, this study which shows Basal plus versus IDEC as this is also a study which shows, if you look at the right-hand side, it shows the glargine 300 versus the Basal plus, 14% higher time in range, 7% lower hypoglycemia, and 18% lower nocturnal hypoglycemia. So these are various studies which I wanted to discuss, and this is the in-range study which is yet to be published. This is in type 1 diabetic. It's a large study studying about 380 odd patients comparing degludec versus glargine 300. I've come to the end of the presentation, and it's over to the chairpersons. If there are any questions, I'll be glad to take them up.
Thank you, Colonel Sudhir Tripathi. I think we had nice lectures by all the three speakers, and we had good discussion. Because of the shortage of time, the questions I think we can ask during the tea break. I thank my co-chairs for the session. Thank you.